Welcome to Distance is No Obstacle, the medical education podcast aimed at providing bite-sized education and information for people working in rural and remote Australia. Today we hear from Dr. Kate Freeman, a consultant paediatrician at the Child Protection Unit at Perth Children's Hospital.
So I've been asked to talk about recognising and responding to child abuse. This is a talk that normally takes me about 2 hours, and I've been given half an hour. So this is a bit of a condensed version. Please feel free to ask questions, and I will hang around afterwards as well if there's anything that we don't get to during the talk. So these are the 4 key R's or key points to give yourself a framework for your approach to child protection. Recognise, respond, record and report, and we'll go through those in the course of this talk. There are 5 main types of child abuse, of which today I'm going to focus on non-accidental injury and child sexual abuse. If we have time, we'll get to neglect. I don't cover emotional abuse or medical child abuse, which is the current term for what was previously known as Munchausen syndrome by proxy. So how does child abuse present? In a number of ways, some a lot more obvious than others. A 4-year-old with gonorrhea, 6-week-old baby with an unexplained fracture, a 9-year-old left to supervise his young siblings while mum's out drinking, or a 14-year-old who's regularly witnessing domestic violence. But as you know, there's a lot more subtle presentations, developmental regression, behavioural changes, inappropriate sexualised behaviours, a huge raft of ways that this can present. Everyone has a responsibility for child protection, whether they experience that in a professional capacity or not, but there are certain agencies, in addition to that, tasked with specific responsibilities. You guys here in health, including us in the Child Protection Unit, are responsible for the medical assessment of child abuse. The Child Protection Unit is based at Perth Children's Hospital, but we are a statewide service, and we can provide advice to anyone concerned about child abuse, but our specific role is in conducting medical assessments for children in whom abuse is suspected. As opposed to that, Department of Communities, as they are currently known, formerly DCP, CPFS, are responsible for child safety in the community, and they also have a number of statutory rights and responsibilities that we don't have. So they have the legal power to take children into care. Doctors have a very limited capacity to some very limited legal powers to keep children safe, but communities have far more wide-reaching powers, and they're responsible for the safety of children in the community. And then WA Police, the other organisation that we work with pretty closely, who are responsible for criminal evidence collection and investigation. When we think about children in whom we suspect abuse, there are 3 key vulnerability factors, this triangle of features that we always look for. They are these are features of the parent or caregiver, mental illness, drug or alcohol use, and family and domestic violence. It's not to say, of course, that child abuse can't occur in the absence of those features, but it almost always, there is one or more, and often all 3 of those features. Other vulnerability factors in the parents include lack of support, poverty, unemployment, lack of education. And then there are certain factors in the child as well, including prematurity, physical, cognitive impairment, any chronic disease, and a parental perception that the child is a difficult baby, has a challenging temperament. So talk first of all about non-accidental injury. I know I'm going quite quickly. Please wave at me if you have any questions or you want me to clarify anything. So there are 4 main types of non-accidental injury, formerly known as inflicted injury: bruising, fractures, abusive head trauma, which we formerly called shaken baby syndrome, and thermal injuries or burns. So across the board, when do we become suspicious about children presenting with injuries of any kind? I think age is one of the major factors that help you to determine whether a child's injury is suspicious or not. The children who are most vulnerable to severe and fatal inflicted injury are young children, and they're generally the children least likely to be injured accidentally. So if ever you're seeing a pre-mobile child, so under the age of, well, you take a developmental history, but generally under the age of sort of 6 months, any injury in that child, you want to be really satisfied that there's a good explanation that makes sense to you before allowing that child to leave your practice. Any injury that's unexplained or doesn't fit with the history or developmental age of the child, any unwitnessed injury, although depending on the age of the child that may be entirely reasonable, inconsistent or implausible histories, delayed presentation for which there is not a good reason. I'm very aware in rural areas there are often very good reasons for delayed presentations. Multiple presentations with previous injuries highlights the importance of good access to medical records for children. And any of the features, the factors, psychosocial factors that we just touched on. A way to ensure that you don't miss things is by using an injury pro forma. I know some emergency departments across the state, and all emergency departments in Metro use injury pro formas. I think they're excellent because they mean you don't miss things. Our practice is to use them for children under 2. I know, for example, Pilbara, Headland goes for children under 16, whatever works for your site. But it is essentially asks you to ask all of the questions that you need to ask, and then it directs you to sort of a risk stratification whereby if you tick certain boxes, it tells you that it's suspicious and then provides you with some suggested next steps for who you might contact. So especially good if you don't see injured children very often, or you have juniors working with you who might not have that experience. It also provides body diagrams, which can be invaluable for accurate documentation of location, size, etc. of injuries. Essentially, I would suggest to you that if you have any injury or any concern about a child under 2, they're likely to need admission, and you would liaise either with your regional paediatrician, or you can always contact us here in Perth as well. We tend to undertake forensic investigations looking for occult injuries in children under 2 in whom we have a reasonably high index of suspicion. We do things like MRI brains. We ask the ophthalmologist to view the retina to look for retinal hemorrhages, and we do a skeletal survey looking for any occult fractures. And we undertake medical photography as well, mostly for medico-legal purposes, for presentation in court. So this young man comes to your clinic. He's 4 months old and he's just popped in for his immunisations, and you happen to notice these injuries to him or these marks on him. What sort of questions might you ask Andrew's carers? Just shout. Yeah. So when, how did it happen? Where? Tell me what happened. Anything else? Yeah, has he ever had bruising like this before, or any other relevant medical history? So any other injuries or any other any red flags in the history that make you think about medical causes for bruising in children? Any other history?
I want to know what his developmental history is.
Yeah.
Is he crawling, rolling?
Yep. So those things are possible at 4 months old, although in this case I suspect he's got bruising over the angle of his jaw, his cheek, and his pinna. They are protected areas in children in young children. Even if he's crawling, they are very unusual places to sustain injuries accidentally, but it is important to take a history. And you probably just delve into the psychosocial history a little bit, looking out for those red flags that we spoke about before. And where's this child going from your clinic? To the nearest hospital. Yeah. Someone's supervising him. Yeah. So feel free. Remember, the person bringing him to the clinic may not be the person who's injured him. If you think it could be that person, so keeping in mind baby and staff safety, either just say that you or your professional colleague at your site will escort the baby via ambulance to the nearest hospital. You certainly won't allow the parents to drive him there. If you think that it's probably safe enough for you and mum and bub to be in the ambulance together, that's okay. But that's a judgment call for you. But no unsupervised contact of anyone with that baby.
And what do we at the hospital do when that patient comes through the door?
In what sense?
Well, the GP sent them
Yep.
in. We are now exactly the same situation.
So you're a regional hospital, ED, emergency department, yep. In a child like this, so a young child with highly suspicious injuries, I would be on the phone to your regional paediatrician and or us in Perth. So if most sites, most areas in WA have regional paediatricians, if you don't, call us straight at the Children's Hospital in Perth. CPU at the Children's Hospital. I can tell you this child is going to end up in Perth because they need an MRI scan of their head because of how suspicious and multi-site, multi-plane, there's multiple episodes of injury that have occurred to this child. So we are a relatively high likelihood of finding occult injuries in this child. So he's going to need a MRI scan, ophthalmology, full skeletal survey. That can only happen in Perth. So if you rang me up with this story, I'd say, transfer him to PCH.
Most of us live in the bush.
Yeah, well, you still have RF, yes.
Yeah, but the other thing is,
This is bad. It doesn't look dramatic, but these injuries.
Could there be another explanation? We're taking a radical step because those parents will never see you again.
And how do you make the parent? I mean, mum just goes,
Yeah.
no, I'm just
no,
going
Yeah.
I'm going home. That's the whole point.
Yeah,
If
okay.
it's a psych patient we can form, but we can't form.
Yeah.
You know, we can't make
These are really good questions. I'm going to need longer than half an hour.
I think you explained that, this is really abnormal to see bruising, like
Yeah.
we need to rule out a medical cause that could have a
Yeah.
pedophilia. So if you don't act like you're
Yeah.
suspecting them, but that you're worried that they have an underlying medical condition,
Yeah.
so that you're not making them feel
Yeah.
right away.
My usual approach to this sort of situation is to say, these bruises are really unusual, or these marks are really unusual. I'm really worried about your child and we need to do some more tests. We can't do those tests at this hospital, so we need to get you to Broome or Kalgoorlie or wherever or ultimately PCH. But often going via the regional site's a little bit easier. Then mum says, no way. Okay, you have if you cannot talk them round, so explore why mum says no. Has she got 4 other kids at home? Is it a practical thing that you can assist her with? Is she hungry? Does she think you're going to take her baby away? Explore all of those issues with her and see if you can reassure them. But ultimately, if mum picks up her baby and walks out, call the police. You have a legal power called a Section 40, and this is why I say just ring CPU, because we can talk you through all of this. You have a legal power for a child under the age of 6 who you believe is at imminent risk of death or serious injury, either from being re-injured or you not seeing this child with serious injuries ever again, or because he's septic and mum doesn't want antibiotics, for example. But you have a legal power to take that child and do with them what you wish. So whilst I don't recommend clinical personnel going and manhandling the baby back, it's not safe, the police absolutely can. They can arrest mum because I don't want this, and we try to avoid this because it's horrible and they really will never come and see you again if you do that. But if you and if you know the family, get grandma, get auntie, get someone who could understand you when you say, I'm really worried about this baby. Chances are, or oftentimes, it's not the mum. Mum is as petrified of the abuser as.
Well, that's why
Yeah.
she's brought the baby in.
Yeah. So there's a lot of sensitivity to it, but ultimately your responsibility is to this baby, and that has to override your reputation. I know it's difficult, but this baby is really vulnerable. These injuries are severe. These injuries are significant in that they have almost certainly been inflicted. I cannot think of any other reason. It's a weird distribution, even if this baby's got haemophilia or some kind of coagulopathy. It's a strange distribution. And you're saying to them, we need to do these tests to look for these things, but ultimately this is inflicted until proven otherwise.
I was more interested about the legal.
Yep, so Section 40, yep. So your district medical, your senior regional medical people should have good knowledge of the legal powers that you have. But if they don't, or if you wish to clarify, we do at CPU, and you can call us. Don't forget your social work if you have access to one as well.
What if they're over 6? It's a different section.
there isn't for you. You as a doctor, you don't have that. Everybody in here is a doctor, I believe. Yeah. So you as a doctor don't have that power for children under 6, but communities do. Over 6, yeah. Sorry. So involve communities because they can enact Section 37, and this is all acts of the Children and Community Services Act. They have that power to take any child into care who they believe is being harmed or at risk of harm, and so. Let your communities officers know quickly, and just go quickly up the chain to the district director if you're not getting traction at a local level. So some other specific questions about falls. Where was the child at the beginning of the fall? Where were they at the end of the fall, or how were they found? And if known, how did they fall and from what height? Most parents who've dropped their child or been in a situation where their child has fallen from their arms can tell you exactly what happened. It's not the sort of thing that you forget quickly. Examination in the standard way, documenting bruises carefully, as I have indicated there, and special sites in injured children are the ears, inside the ear and behind the ear. With a good light can be bruising within the ear. Pinna can be hard to spot in children who've got heavy skin pigmentation, so have a good look. And then in the mouth, the frenulum and the palate. Bruising cannot be aged. Don't let anyone tell you otherwise. This is in children. So suspicious bruising, as I said, heavily dependent on age as to where of sites of bruising where you might expect accidental bruising to occur. So in context, a child who's non-mobile, less than 1% of them will have bruising, in contrast to a child who's walking who will have on average 5 to 6 bruises. Any bruising located away from bony prominences is suspicious, especially in pre-mobile children, and that's the abdomen, face, chest, buttocks, or occurring in naturally protected areas like the eye sockets, the cheeks, the ears. Cluster bruising, so multiple bruising at the same site, or imprint bruising, which is where the bruise takes on the shape of the object that's inflicted the injury. And if you have the object, can you send it down with the child to Perth? It's quite helpful for us. Fractures, again, I'm just going to very sort of briefly cover these things. And again, it's all about age. Non-mobile children should not have fractures. They can have them, there can be innocent explanations, but you need a good story and you need to believe the story. Children under 1, around 80% of those who have a fracture, it will be due to abuse. And then across the board, certain fractures have higher specificity for abuse. Metaphyseal fractures, so corner or bucket handle fractures, so little chips off the corner of the long bones at the ends, any rib fractures. Humeral fractures, especially if they're spiral or oblique, generally a twisting injury. Femoral fractures in non-mobile infants. I just selected some images to show you of metaphyseal fractures, and then I've got one here of rib fractures from a case I saw recently. This was a 6-week-old with bruising, and we found quite a few fractures in that baby. Can anyone see the rib fractures? It's the 7th and 8th. So the posterior. And I think I put this one up not to frighten you, because they're not easy to spot, but to ask you to ensure that you have a robust method of following up your radiology reports at your local site. You could be doing a chest, and this actually comes up quite a lot, is that you're doing a chest x-ray for bronchiolitis. Well, you shouldn't be doing a chest x-ray for bronchiolitis, sorry. You do. A child has a chest x-ray for a medical reason, and someone has a quick look at the lung fields, and off we go. And then somebody else, maybe in a different country, types a little report saying there's some healing rib fractures there, and the two don't all marry up. So please make sure you've got robust follow-up processes for your reports, and that anything that's suspicious, just call us and we can talk you through what the next steps might be. It's absolutely not an outpatient referral, which I did receive recently for a child with bilateral femur fractures. So just call it. We're quite nice. We'll always talk to you. And if it turns out that it's nothing's to be done, well, it's nice to have a chat. And we're always happy to talk to you. So abusive head trauma. Almost all children under the age of 12 months with severe head injuries, it is due to abuse. Features of inflicted head injuries, so any face or scalp injury, including soft tissue injuries, so any bruising to the head or face, skull fractures, subdural hemorrhages, retinal hemorrhages, and any fractures. Okay, and we often see 3 or 4 or even all of those together. And the outcome for these babies is not good. Okay, so I think I've got 10 minutes left. Burns, far more commonly due to neglect than being directly inflicted, so consider that when you're seeing these children as well. There are, again, certain patterns of injury that we find suspicious and certain patterns that are accidental. We all know that children commonly scald themselves. The classic is the toddler pulling up the cup of hot tea. Features of innocent or features that make you think it is more likely to be accidental would be usually anterior trunk, maybe arms. It's asymmetrical, there's splash marks. Absence of those features, such as the images depicted here, are suspicious. Glove and stocking distribution is consistent with being dunked and held in water, that clear margin, and it's symmetrical. A developmentally normal child, when they make contact with hot water, will immediately recoil. There'll be splash marks. It will be asymmetrical. Clearly that's not seen at all in the picture there on the left. Picture on the right there, just something to look out for is when you've got, again, these clear margins but with sparing around the buttocks, which is where it's had contact with the base of the receptacle holding the hot liquid, and then some sparing around the tummy as they are held, bent, and dunked and held underwater. Okay, so child sexual abuse. I might just move a little bit quickly through this so that we get to the end. So child sexual abuse occurs when a child is exposed to or involved in any sexual activity that's inappropriate to the child's age or developmental level. It can take various forms, including touching or fondling, penetration, exposure to inappropriate material through pornography or exhibitionism, and child sex rings or prostitution. It can present in a number of ways, and we did touch on that before, either a direct or reported disclosure, inappropriate behaviours, developmental behavioural regression, physical injuries, infection or pregnancy. I might just move through these slides. I'm happy to talk in more detail afterwards. So as a general point, again, happy to be called. Not all children require an examination. Not all children require the examination at the point that you're seeing them. It may be more appropriate that other things happen for them first. We never examine children against their will, and we never sedate children for an examination unless it's for a medical cause. In other words, we think we're going to find severe injury, so a child who's got a lot of bleeding, for example. And clearly we need consent. And so if the child or parent is intoxicated, it's not appropriate to proceed. All right. Again, I think I'll just better keep going. With respect to genital injuries, most children who have a clear history of abuse have a normal examination. So I think it's very important when you're talking to parents and young people in advance of the examination to say that you suspect this exam will be normal, and this doesn't mean we don't believe you. We know this happened because you told us it happened. And an examination allows us, or we're looking for injuries or any medical problems that need treatment, and sometimes you might take some forensic or medical tests as well that you speak about. There is still a lingering perception amongst parents that you can do like a rape kit they call it, or we can look at the hymen to say whether they've ever had sex, because it's broken. The hymen is a circular ring of tissue. It doesn't become broken, it can become damaged in various different ways. And certain types of damage are more specific for abuse than others. But we will not examine a child because the parent wants us to, if there isn't a medical reason to do so. Okay, so investigations are broadly speaking in two categories: forensic, which is for the purposes of police investigation, and they have to be collected in a manner that preserves the chain of evidence and prevents DNA contamination. And then medical tests for infections, so you might do urines, and in fact, in reality, with most young children, we do urine PCRs for chlamydia and gonorrhea. It's a non-invasive test that most kids are happy to provide. If there is a risk of bloodborne virus infection, so penile vaginal or penile anal penetration, we will do bloodborne virus screening as well. And don't forget to do a pregnancy test in anyone who might possibly be pregnant. I will direct you to our website, the CPE website, which has heaps of useful resources on, including full video demonstrations of how to conduct examinations and do investigations in children who you think might have been sexually abused. So I'll give you the link to that at the end. Medical management, post-coital prophylaxis, so if they're not pregnant, give them the morning after pill. I recommend that you do that at the beginning of the time that you spend with them. A lot of young people vomit the pill back up, and if they vomit within 2 hours, they need to have it again. And I would keep them until you know that they haven't vomited it back up. So I normally, as soon as I've established that they need the pill, I explain to them what it is and give it to them, and then we go through all the other stuff, the investigations, examinations, and so on. But I will have excluded pregnancy before giving it, is the only thing.
Why would you think that they would vomit it out?
Because it makes people vomit.
Oh, I see. They're not doing it because they want to.
Oh no, it's nauseating. Sorry. Yes, yeah. And if you give it the second time, just give it with ondansetron. STI prophylaxis in children in whom it is relevant. So ceftriaxone and azithromycin. So I usually put a line in, pull off the relevant bloods, give the ceftriaxone and pull the line out, and then give them oral azithromycin. If they are not hepatitis B immune, which you will establish from your blood tests, you need to recall them for, and they are at risk of contracting Hep B, I would recommend that they're recalled for the immunisation and immunoglobulin. If you are considering giving NPEP or HIV prophylaxis, as you know, it's a multi-drug regime that they need to take for 28 days with multiple side effects. Please, can you talk to us about it first? It's an expensive drug. We'll probably have to send it up from Perth. It doesn't mean we can't do it. We just need to make sure we're giving it to the right kids for the right reasons. Mandatory reporting. This is a take-home slide. By law in WA, you must, as a doctor, make a mandatory report if you formed a reasonable belief that CSA has occurred. Okay, reasonable belief is at your discretion. But if you have formed a reasonable belief and you don't do it, you can go to prison or receive a large fine, and that has recently happened to some teachers here in Perth.
If we have a reasonable belief and then we admit them on the reasonable paediatrician, who then transfer them to Perth, do all of us involved in that chain?
The first mandatory reporter seeing the child has the legal responsibility. Every subsequent mandatory reporter needs to check it's been done. So you would do your mandatory report and scribble in the notes MR tick as the first mandatory reporter seeing them. And then when we get to Perth, when they get to Perth, if I cannot see that someone's written that in the notes, I will do one myself. It takes 2 minutes. And no, absolutely not, no. And those reports go to police and communities, and remember it's a time critical thing as well. So the sooner the better, because that triggers the investigation from police and communities. And that there is the link. I will move through neglect, but I will provide these slides to you afterwards. All right, so take-home messages: recognise child abuse. It is common. there are certain patterns that you can learn to recognize, and failure to heed those warning signs can lead to serious injury and death. Those little bruises on the face there that you might think, oh, they're just little bruises, that kid has a pretty high chance of coming back to your ED dead or almost dead with lifelong disabilities. Okay? Don't panic, don't dismiss, just keep the child where you can see them and contact your regional paediatrician or us for advice about what the next appropriate steps are. Proceed in the normal way: history examination, investigation and treatment. Record your concerns carefully and report either through mandatory reporting, which relates just to sexual abuse, or there are alternate pathways for reporting other forms of abuse, again also linked to on our website. And you may also need to make separate referrals to police and communities. So some useful resources: Department of Communities. You all have your local, regional communities office. May I suggest you put that number in your phone so you have easy access to it. Communities is a 24/7 service, and their after-hours service is called Crisis Care. The country number is different to the city number, so the country number is 1-800-199-008. There is also a mandatory reporting hotline. Your legal responsibility with MRs extends to the written report, but you may also call them for advice, and they are pretty good. So that's 1-800-708-704, that's sexual abuse. Medical concerns: we are at the Child Protection Unit in PCH, and we're on call for all forms of abuse 24/7, and you can contact us via PCH switchboard. Here is a link to our intranet page that you can access through any WA Health computer, and that is sort of what the front page looks like, but it's got a lot of resources on there that you may find helpful. It's got our direct contact details as well. You can leave feedback for the website if there are other things you would like to be on there that aren't on there at present. Okay, I'm aware I've gone over time. I'm sorry about that. Are there any questions? Yes.
Do you report all STIs and up to what age group?
Yep.
Is it dependent on the culture that they come from?
Is it dependent on the?
Cultural background.
Oh, that is a huge. I mean, that's 3 hours answering itself, isn't it? So there are two types. You have two lines of reporting responsibility. One is Department of Health, infectious disease notifications, and STIs. Most of them are notifiable diseases to the public health authorities. Regarding the sexual abuse aspect of it, you have a legal responsibility to report all STIs in children under 14, okay, following the mandatory report process, children under 14, all right? By making an MR, you're not condemning anyone to arrest, jail, whatever. It's just, it triggers a process for further investigation that you can't do within your confines in health. It triggers a multi-agency response to look at, is this child vulnerable? Do we need to do anything to keep them safe? Are other things going on in the community for this child? So I'd say report STI, well, you must report STIs under the age of 14. Between 14 and 16, you have a little more leeway. Do you, and your question about culture, it is in no person's culture to spread STIs. We have to be clear about what we expect for children in our country, regardless of their cultural background. There are many cultural practices across many cultures that are different and diverse and are different and acceptable ways of doing things. There are certain practices that are more common in certain cultures that are abusive, and the cultures, the background that child comes from should not influence your willingness to report that abuse. We have to stand up for children, regardless of their cultural background and how difficult it makes things for us. So between 14 and 16, a bit more leeway as to whether, you think that, did everybody consent, and can everybody kind of follow up with the recommendations? And, you could say, is a 15-year-old getting an STI really I'm a bit worried that's a child protection matter, because it implies a degree of sexual promiscuity, such that their health is jeopardised, their physical health is jeopardised. So I kind of think about the individual situation. Again, we can talk you through some of the pros and cons in children you're not sure about whether to do it if they're between 14 and 16. Yeah.
I'll be last question, please.
Yeah, how do kids get a toy when they're young?
So either being shaken or having things forced into their mouth.
Is there any way they can get it without?
Yep. So you just ask the parent what happened. So, I was holding him with a bottle in his mouth and I tripped and the bottle went like that.
Yeah.
Innocent explanation. Yeah. They'll know because, little babies, there's an adult with them all the time when they're very young. Yeah. So does it make sense?
One more question, Dave.
I'll hang around after and feel free to come and ask as well.
This is a different question. You make reports when we have suspicious cases. What if you find a newborn baby in the toilet?
As in there's no mother? Abandonment, yeah. Yeah.
Do we make a report or just call the police against them?
Yeah, so child abandonment is clearly a child protection issue. I would recommend that you make a medical assessment of whether there's any signs of harm to that child. So as in they've literally just been born. They've not been left on the street for 5 hours. They haven't not been fed for 12 hours. Okay. So if you are medically satisfied, there are no medical issues for that child, Department of Communities would be your first call. Okay. If there are any medical concerns, you may need to involve us as well. No worries.